Welcome, everyone. Want to extend a warm welcome to everyone who's tuned in today to this virtual training on advanced HIV disease in the context of the COVID-19 pandemic in Africa. My name is Dr. Bruce Struminger, and I'm an associate director at the ECHO Institute at the University of New Mexico. And I am going to be just going over a few housekeeping items before our formal welcome from Tom Chiller. Hopefully you can all see here the agenda. Just a couple housekeeping items. Please use the chat, or if you've got an IT issue, please chat ECHO IT to troubleshoot any Zoom problems you might be having. Try to reserve the Q&A feature for questions and put as many of your questions there rather than in the chat. And we will be monitoring those questions and doing our best to answer as many as we can. The presentation slides and a recording link will be shared by email for everyone who registered after the session, probably within a day or so. So look out for that. The session is being recorded and your attendance is consent to be recorded. So thank you for that. There will be continuing professional development credits available through the University of New Mexico. We will be sharing a link in the chat about 15 minutes or 10 minutes before the end of the session. And you'll cut and paste that link into your browser. It will take you to a survey. And after you answer about 10 questions, which will help us to improve what we're doing through these education efforts, you will get instant CME credit. So we really encourage you to take advantage of that, and we welcome you to this exciting session. And Tom, I'm going to pass the baton to you for the formal introduction.
Thanks, Bruce, and thanks everybody for joining in this virtual webinar today about advanced HIV in the era of the COVID-19 pandemic, a real challenging time for all of us in public health and the medical community. We wanted to host this webinar today to just keep momentum going in caring for those HIV patients in the most need, those with advanced disease. And we know that when we're challenged with other medical problems and issues that come up, especially outbreaks like the COVID-19 pandemic, we're challenged with taking care of our patients that still require us to do good medical work and public health. And I know here at the CDC in Atlanta, although as you can tell, I'm at home, most of us now are working from home, as I'm sure many of you are, except for those of you who need to go and take care of patients in clinics. We're all trying to continue to do good public health for not just those patients with COVID-19, but also with all of our patients and public health problems beyond COVID and that continue to exist. And so what we hope today to do is not focus on COVID-19, but talk a little bit about advanced HIV. And specifically, we're excited to have two clinicians that will talk to you today about cryptococcal meningitis and some of the newer or maybe more exciting developments on how we might be able to take care of patients, especially in these challenging times. So let me start by giving a brief intro, and I'm going to open my presentation up, so bear with me for a couple seconds here as I get used to the new Zoom presentation format. I hope you all can see. So as mentioned, this is the first webinar, hopefully on a series of webinars that we will try to do talking about advanced HIV disease during this unprecedented time. And as I mentioned, we will focus on crypto. You know, we in public health, as all of you, I'm sure, deal with on a daily basis, are used to so-called pandemics. Clearly, HIV/AIDS has been now with us for decades, and we're still losing hundreds of thousands of people each year. TB, considered a pandemic as well, still losing over 1 million, 1.5 million people each year. Cryptococcal disease, which is something we're going to talk about today, is estimated to cause up to a couple 100,000 deaths each year. And then, of course, COVID. And as of yesterday, when I think I made this last slide, there were around 165,000 deaths already reported. And we obviously expect, unfortunately, that number to continue to rise. So as already mentioned, why we want to do this now, why are we doing a webinar on crypto and advanced disease? Well, we want to try to think about how we can reduce collateral damage from these other diseases during this pandemic. And so HIV, as we all know, doesn't go away, nor do people who are getting sick from HIV. And in fact, because of some of the things that are happening, it could be we're seeing more patients with advanced HIV. So we don't want to stall our efforts in addressing this important problems. And we also want to consider potentially more efficient ways to actually deal with caring for patients with advanced HIV. And here's a nice graph that just illustrates our fears, I think, in public health. And that is using Ebola as an example. We see that there are indirect problems when you focus all your efforts on one disease and how it can affect the care and actually the treatment of these other diseases. And if you look at HIV, TB, and malaria all combined, Ebola actually had a drastically negative effect and increased mortality in those particular diseases during the West African Ebola crisis that we had. And we don't want to repeat these same things during COVID. And again, this just talks specifically about some of those lessons learned, where the Ebola response placed severe strain, as you all know who were dealing with it, on healthcare delivery. Lots of demand, healthcare worker risk, which we're dealing with now, resources being diverted, closure of healthcare facilities, which we're dealing with now. And so, again, this led, unfortunately, to excess deaths in measles, HIV, TB, and malaria. And so we're wanting to think about how that's going to affect us in this new pandemic. I wanted to remind everyone about WHO and putting together a package of care to try to simplify how we deal with advanced HIV disease in our patients. We know that the most important thing to do in HIV is ARVs, is getting people on antiretrovirals. That is probably a priority number 1, 2, and 3 with our patients. But we also realize that a certain percent, and unfortunately that percent hasn't changed much, are still presenting or representing with advanced disease. And there are some simple things we can do to try to screen for diseases like crypto TB, get people on prophylactic medicines like cotrimoxazole, and prevent them from dying of advanced HIV complications. Specifically talking about cryptococcal disease, which we're going to talk about in this webinar, antigen screening is now clearly recommended for below 100 CD4, if not below 200. There are more data coming out suggesting that a patient with advanced disease, as we define as a CD4 count below 200, also benefit from cryptococcal antigen screening. Using fluconazole as a preemptive therapy, we know this can reduce the number of people that go on to develop cryptococcal meningitis. And you can see here that over the past decade, really, cryptococcal screening, CRAG screening, has really spread to encompass many national guidelines, including the US, where I live and practice, but impressive the amount of African countries that have adopted this strategy, at least in guidelines. And of course, applying it is a whole nother challenge. And you can see here that a couple documents now have come out over the last 3 years that really highlight and show the details about this. So jumping back into COVID and advanced HIV, here the big question is, are people living with HIV at increased risk of being infected with the virus that causes COVID-19? We know people living with advanced HIV, those with low CD4 and high viral loads, and not taking antiretroviral medicines like we're talking about today, have higher complications in general from all kinds of opportunistic infections. But it's unknown, at least at this time, whether COVID-19 puts these people at higher risk. So far, it is generally felt that patients with HIV, even with advanced disease, are not necessarily at higher risk for COVID-19. But we all know in taking care of this population, we need to be worried about co-infections and opportunistic infections. And again, that's one of the reasons why we're here today. So we need to remain alert for other diseases in this era of COVID. And as we think about diagnosing COVID, we need to remember that TB could be similar. They may overlap. Patients with HIV, even crypto symptoms may overlap or confuse and be thought about COVID. So it's important to message that we need to address the risks that any sick individual may be dissuaded from seeking care because they think they have COVID, and they actually may have one of these other conditions that we really need to be focusing on. There are a few signs, unfortunately, that some of our advanced HIV disease initiatives may be stalling. Coordination, supervision, training activities, as you all know, for many HIV programs and their implementing partners are being reduced, suspended, or even canceled because of COVID. We know this is going to impair the coverage of what's happening. And so it's just going to be important to be thinking about this. And I know some of these things are unavoidable, but we know that our patients with advanced HIV need our help. And so we need to be thinking. I think supply chains for some key commodities have already been disrupted, including diagnostic tests, including drugs coming out of China, coming out of various places. This is going to be a challenge for all of us, and we need to be thinking about that. And that's one of the reasons why we're excited that ECHO is helping us do this webinar and other virtual support meetings that are going to be important as we move forward. So I want to mention 5-flucytosine as an exciting potential way to advance our treatment and our thought about how to deal with cryptococcal disease. It allows one to do a all oral treatment for cryptococcal meningitis. You're going to hear about that in a moment, and reduce contact with the healthcare system because of this. And that's sort of exciting because we've seen that as flucytosine is being rolled out very early, that it could save hospital beds, cutting treatment from 2 weeks to 1 week of in-house treatment. It's very easy to use because it's all oral, and you get an option if inpatient beds were completely full due to the pandemic, that you could actually treat people with an all-oral option. And I think this is exciting. And again, I'm not going to mention much about that now. You're going to hear from our two other speakers. There are currently those manufacturing flucytosine that they say they can continue to supply demand. Countries have to demonstrate that and ask for it, but the drug can be there and can be brought to bear. So here are some supporting resources that I'd like to point you to. And again, these slides will be made available. Thanks for your attention and your time, and exciting to hear now from Dr. David Meya. Dr. Meya is from the Infectious Disease Institute in Uganda, and he's going to talk specifically now about cryptococcal meningitis treatment and management. So I will stop saving my screen now, if I can figure out how to do that. There we go. And I will turn it over to you, David. Jutta, I believe you're going to share your screen for David.
Thank you very much, Tom. So I just wanted to quickly dive into cryptococcal meningitis management specifically. And I think, as Tom has already alluded to this, the burden of cryptococcal meningitis remains a significant problem. Next slide. if you think about the COVID numbers, just in terms of the mortality, you know, we're approaching a figure of about 180,000 deaths probably by the end of this week, unfortunately. But if you think about how many people actually die from cryptococcal meningitis, you know, the annual global deaths are estimated at about 180,000. And this has been going on for a couple of years now. Probably in the years prior to this estimate, there were obviously many more deaths that were occurring annually. We also know that cryptococcal meningitis is responsible for about 15% of all AIDS-related deaths. And Africa is obviously, sub-Saharan Africa is obviously bearing the brunt of the majority of this mortality, with almost 136,000 deaths occurring annually. So just as a very quick look in South Africa, 2017, you know, as they were starting to roll out their focus on advanced HIV disease with cryptococcal meningitis, cryptococcal disease more broadly, they detected about 6,600 cases just in that year alone. And about 60% of those patients with cryptococcal disease were on ART at the time they had this diagnosis. We'll come back to talk about this this statistic at some point in the presentation. So we'll quickly have a fast polling question. Yuta, if you can bring that up.
Sorry, Connie, can you share? It's causing a problem with the polling. I'm sorry, the slides.
Okay.
Do you get it? You there?
Yeah, that's it. So our fast polling question is, you know, do you perform cryptococcal antigen screening in your facility? So if you could quickly respond to that, just to have an idea of, again, pointing back to what Tom had sort of introduced in terms of how many countries have included cryptococcal antigen screening in their programs. So we'll just give this a few seconds for people to respond. Okay, maybe we could quickly look at the result. Right, so it's about 55% have screening in your facilities and 45% do not. So yeah, this is clearly a problem. And as we go along, we will sort of continue to discuss the importance of this result, of this polling question. Next slide. So I wanted to just go on and quickly talk about the indications for cryptococcal meningitis treatment. But just as, you know, before I dive into that, just to come back to the issue of crowd screening. So in order to identify who has cryptococcal meningitis, I think the first step usually has to be, or ideally should be, identifying patients who have a serum cryptococcal antigen test that's been done, and then going on to determine whether they do have symptoms or not, symptoms of meningitis or not. And as we know, you know, headache, nausea, vomiting, they might have photophobia, or neck pain or stiffness, the sort of symptoms that one would be looking out for. And so it's important that as many countries and as many facilities as possible should be able to do cryptococcal antigen screening, because that sort of serves as a first entry point for people that have cryptococcal meningitis or cryptococcal disease. So we know that in order for you to determine who has cryptococcal disease, as I've already outlined, doing lumbar puncture ideally is the most ideal. There are many facilities that are not able to do a lumbar puncture, and so that needs to be taken into consideration. However, we also know that there are individuals who have a positive serum CRAG, who have symptoms of meningitis, but when the lumbar puncture is done and the CSF is analyzed, the CSF CRAG might be negative. And so Kenneth Sabambulide, in a study that was published last year from Uganda, found that the mortality rate among those who were serum CRAG positive but had symptoms of meningitis with a negative CSF CRAG had almost similar mortality in hospital as individuals that had positive CSF CRAG. And so that was ranging from about 30 to 32%. And so one of the indications is if an individual comes in and they're serum CRAG positive and they do have symptoms of meningitis, but you're not able to do a lumbar puncture, it's important, you'd rather err on the side of assuming that they do have cryptococcal meningitis and therefore treating them, as we'll sort of go ahead to see in the next couple of slides. If you're able to do CSF analysis and you detect in the CSF a positive India ink, a positive CRAG, or you're able to culture the CSF, regardless of the symptoms, you should be able to consider that that individual has cryptococcal meningitis. However, the caveat here is obviously that there will be individuals who may have had cryptococcal meningitis before, who may show up with symptoms of meningitis. It could be another type of meningitis. However, their CSF CRAG might still be positive because it does stay positive for a while. And so for those particular individuals, I think making sure that you're able to get a culture would be important before you commit them to cryptococcal meningitis treatment. Among individuals who show up with recurrent symptoms of meningitis and have a positive CSF culture, again, it's important to consider that as possible relapse of meningitis. And those are individuals where you need to think about the possibility of fluconazole resistance. And if you have the facilities and you're able to evaluate for fluconazole resistance, it would be important to do that in that population. If an individual has had a specimen taken either from any other site and it's cultured and it's positive for cryptococcal disease, those individuals need to be treated as having disseminated cryptococcosis. Next slide. And so one of the things that we wanted to highlight, and as Tom had already alluded to, the UNITAID has some funding, a grant that's going to be supporting the rollout of flucytosine and liposomal amphotericin in a couple of countries in sub-Saharan Africa. And so it's sort of riding on this background that we, again, wanted to sort of highlight specifically these two drugs, flucytosine, which is going to probably be supplied by Mylan. We know is a more effective partner drug with amphotericin, having a rapid absorption with a bioavailability of between 75 and 90% after oral administration, and the plasma half-life usually stretches between 3 and 6 hours. It's eliminated by the kidneys fairly rapidly, and but plasma clearance is closely related to the creatinine clearance. And so among individuals who have renal insufficiency, we know that that half-life can increase up to 85 hours. And we'll touch a little bit on this later in the presentation. Unfortunately, it's a category C drug in pregnancy. We don't really have much data, including data on for people that would use it during lactation, and it's not yet registered in most countries. But we hope that this is something that will change over the next couple of months. The other important drug is liposomal amphotericin. and this is mostly sold as Ambizome, manufactured by Gilead. And so compared to amphotericin B deoxycholate, which is available in a couple of countries, it has similar efficacy and less nephrotoxicity. Although it's registered in South Africa, we know that the price is fairly expensive. It's fairly high. There are a couple of countries in Sub-Saharan Africa that haven't yet registered this particular compound, the liposomal amphotericin. But as I said, efforts are going to be underway to have that registration completed. Next slide. So we do have our next polling question. Yuta, if you could show that up. Right, so we just wanted to know how many of you have experience using 5-FC to treat cryptococcal meningitis. And so again, a quick yes, no. We'll give it a couple of seconds for you to respond. Okay, so 91% do not have experience using 5-FC. And so this is why this is important. We have another polling question. This is really regarding the common side effects of 5-FC. And I know that 90% of you don't use it, haven't used it. But for the 9%, 10% who have, if you could quickly respond to this one, really looking at what the common side effects of 5-FC are. Okay. Okay, that's correct. So the commonest side effects are really neutropenia and thrombocytopenia, but we'll go into a little more detail later in the presentation. Our next question is really looking at those who have experience using liposomal amphotericin.
Sorry, David, do we have another polling question? Oh, here it comes. Great, thanks. Thanks. Go ahead, David, it's up.
The question is really regarding the use of liposomal amphotericin. And about 75% don't have experience using liposomal amphotericin. So it's been used a little more by individuals. There's a little bit more experience with liposomal amphotericin. So the next one is really about the advantage of using liposomal amphotericin. Just have a quick look. Okay. And so again, for those that have some experience using liposomal amphotericin. Okay, good. So we'll go on to the next slide. So yes, it does have less nephrotoxicity, and we'll go ahead to look at the details of that. And so the next slide is really coming back to look at why did we come up with the current guideline that suggests using 5FC. So we know that the ACTA trial that was published in 2018 demonstrated that 5FC was superior to fluconazole as a partner drug with almost 40% reduced hazards of death at 10 weeks. Next slide. And we also know that this trial looked at different combinations of antifungal drugs, and the antifungal combination that had the lowest 10-week mortality was a 1-week combination of amphotericin B and 5FC. Next slide. So the current standard of care in many settings, and as we all know, cryptococcal meningitis treatment is really split up into the induction phase, consolidation phase, and maintenance phase. And so what's used in most countries is for the induction is really the 2 weeks of fluconazole, 1,200 milligrams combined with amphotericin deoxycholate. Consolidation has typically been 8 weeks of 800 milligrams of fluconazole, and in the maintenance phase, 200 milligrams of fluconazole. This is ideally given for about 12 months, and once the CD4 count gets to above 200 and you have viral load suppression, I think the new guidance now is that you can discontinue the fluconazole secondary prophylaxis. Next slide. So the standard of care is ideally a week of flucytosine combined with amphotericin B for a period of 1 week, and then followed by 1,200 milligrams of fluconazole. The consolidation and maintenance phases sort of remain the same. Next slide. There are some alternative induction regimen options. So if you don't have amphotericin B, the oral regimen that's recommended is 2 weeks of fluconazole combined with flucytosine. If you don't have flucytosine available, 2 weeks of amphotericin B deoxycholate combined with fluconazole. That's typically given for a period of 2 weeks. In patients who have renal dysfunction and you have liposomal amphotericin, ideally you would initiate, just based on WHO guidance, you would initiate liposomal amphotericin over amphotericin B deoxycholate. Next slide. We can't run away from timing of ART in cryptococcal meningitis, and we all know that based on the CORD trial results, immediate ART initiation in a patient with cryptococcal meningitis and who was ART naive is, supposed to be deferred for about 4 to 6 weeks. I think the big question that hasn't been discussed very well is, what do you do in people who, for example, are CRAG screened and have recently started antiretroviral therapy and have cryptococcal meningitis. So there's still some debate as to what to do with their ART. We know that a study out of Uganda suggested that people who had started ART and had meningitis, sort of if they had started ART within 2 weeks, had higher mortality. But again, we probably need more studies to look at this question. Next slide. And so I'll quickly go on to talk about amphotericin B. We know that this should be given over 4 hours to avoid arrhythmias. It ideally should be given as 1 milligram per kilogram. And that's, in a 1 liter bag of 5% dextrose. I suppose most places might have 500 ml dextrose bottles. Renal toxicity is more likely in the 2nd week of treatment. That's if you're using the 2-week regimen. And it's important that you monitor fluid input and output, and that you supplement potassium and magnesium. Next slide. Fluid and electrolyte management helps to avoid hypokalemia and renal failure. And so it's important that you prehydrate patients who are being treated with deoxycholate with a liter of saline combined with 20 millimoles of potassium chloride that's infused 2 hours before. And once you've given the drug, you then supplement with potassium twice daily, as well as magnesium as well. Next slide. So while on amphotericin B, it's important that you, first of all, find out what the baseline potassium and creatinine are, and then repeat those 2 to 3 times weekly. And it's important that you especially do this in the second week, because that's where most of these adverse events occur. For hemoglobin, it's also important that you monitor that on a weekly basis. Next slide. One of the biggest issues with amphotericin deoxycholate is infection at the IV site. And so patients will typically get chemical phlebitis. And so it's important that you monitor the IV insertion site on a daily basis, flushing the IV lines with normal saline immediately after giving the infusion. It's also important that you don't leave the empty bag attached to the IV line. And so whether this is a question of teaching the attendants of the patient to let the nurses or healthcare personnel know that the bag has run out so it can be removed, is something that needs to be done. And if the patient develops a fever or you notice redness or discomfort at the insertion site, it's important that you consider that as a possible thrombophlebitis, which can become complicated. Sometimes what we've done is rotated the IV insertion site every 3 days just to prevent phlebitis. Next slide. Moving on to liposomal amphotericin, again, which is less familiar to most people. It's really indicated in individuals who have a baseline creatinine clearance that's less than 50 mils per minute. If a patient is on treatment, for example, with deoxycholate, and their renal creatinine clearance drops to less than 50 mils per minute, it will be, at this point, it would be good to switch to the liposomal amphotericin. The dosing is ideally 3 to 4 milligrams per kilogram per day. And if you combine that with flucytosine, it will be 100 milligrams per kilogram per day, and that's divided about 4 doses. Typically, this is followed by a week of fluconazole. I already mentioned the dose. And you need to remember that you should ideally dose adjust fluconazole and flucytosine for creatinine clearance. I think it's important to remember that the other principles of safe amphotericin deoxycholate administration should be followed as well. Next slide. So in order to dose adjust, ideally you should, if the creatinine level increases by more than 2-fold from the baseline value, it's important that you increase your prehydration, probably consider omitting a dose of amphotericin. And so sometimes you might want to give alternate day amphotericin rather than continuing to give it every day. You might want to reduce the dose of amphotericin to 0.7 milligrams per kilogram. And remembering that if the creatinine continues to rise, you might consider discontinuing amphotericin B completely and continuing with fluconazole only at 1200 milligrams. Next slide. So we'll quickly move on to 5-FC, and we've talked a little bit about this already. It's dosed every 6 hours. Occasionally, patients may have nausea and vomiting, but you can sort of stretch out how much you are giving, how you're easily dosing, sort of think of a 15-minute window to give the drugs. The important thing that we highlighted already was that it can cause bone marrow depression, neutropenia, and thrombocytopenia. But typically monitoring for 5-FC is not routinely required. However, next slide. One needs to think about the dosing schedule and how that sort of relates to any renal or bone marrow depression. This is a very simple card that could sort of be printed and used by clinicians who are giving or prescribing the 5FC. And so it's by weight band and how many tablets you'd sort of be giving. And so it's something that don't necessarily need to memorize, but would be good to have as a pocket card or at the nurse's station. Next slide. It's important that as people use 5FC, you ensure there's adequate hydration. If the creatinine remains high or climbs despite increasing gut hydration, you might want to use 2 weeks of fluconazole 5FC. Avoiding nephrotoxic drugs would also be important. And hyperkalemia can also result from acute renal failure. Next slide. And so if individuals have renal impairment and you would have to dose adjust the 5FC because you don't want, as we mentioned already, the drug is excreted through the kidneys. And so the half-life will be prolonged if an individual has renal insufficiency. And so the dosing has to be adjusted in that regard. In individuals who are on intermittent hemodialysis, you might want to increase how long you're giving the drug over time. Next slide. So we have another polling question. I think it's the last one. So do you typically use fluconazole monotherapy? So how many of you sort of use fluconazole alone to treat cryptococcal meningitis? Okay. Right, and so it's a sort of a split between sometimes and using a combination of Tericin 5FC of fluconazole. So about 20% will still always use fluconazole monotherapy. Okay, next slide. So that was really just the introduction to the use of fluconazole. We know it's available more widely than the other two drugs that we've talked about. The 200 milligram tablet is probably preferable because then you use using fewer tablets, and typically used for maintenance and consolidation. Could also be used as an oral suspension. It's been used for vaginal candidiasis or pharyngeal candidiasis, as those patients with advanced disease might have these as concurrent infections. In patients who have liver disease or there's evidence of clinical liver disease, you have to be a little more careful about monitoring, as fluconazole may cause liver injury. The last part of this talk is really going to focus on intracranial pressure measurement and therapeutic lumbar punctures. So the recent ACTA trial results were really in the context of settings where therapeutic lumbar punctures were used. It's important. We know that in most places, the manometers are not available. I know that there are places where the clinicians have sort of improvised by using tubing, IV tubing to measure what the pressures are. That might work or might not work for you. But we know that approximately 15% of patients who come in with an initially normal intracranial pressure will develop raised intracranial pressure during treatment. It's important that one monitors patients daily for headache or signs of raised intracranial pressure that might potentially prompt an LP. 2014 publication out of the CORD trial suggested that therapeutic lumbar punctures had 69% relative survival benefit. And so that's why this is important. Next slide. So when should you measure the intracranial pressure? So obviously at the time of the initial lumbar puncture, and when you do repeat the lumbar punctures as well. So some facilities will have specific days with a lumbar puncture schedule for patients who are being treated for cryptococcal meningitis. And so whether that's on day 0, day 3, day 7, day 10, and day 14, depending on what regimen you're using. But if there are obviously recurrent symptoms, it's important that you either continue doing the lumbar punctures daily, and if patients are not improving, the question is whether you have a cryptococoma that's sort of raising the intracranial pressure, or whether you have suspected treatment failure. Next slide. So if your pressure, the opening pressure is raised above 25 centimeters of water, ideally removing 10 to 30 mils of CSF would be important. The principle is really to reduce the pressure by about 50% from what it was initially. And so the other, as I said, symptoms might sort of dictate when you will repeat the lumbar punctures. Therapeutic lumbar punctures typically relieve symptoms, and that's something that patients sometimes might even ask for on their own. Next slide. We'll skip this. Next slide. So just to summarize, the early diagnosis of cryptococcal disease remains important. Crowd screening needs to become standard of care, and it's important that you know the drug combinations you're using and what to monitor for. With cryptococcal meningitis in the setting of recent ART initiation, as I said, we don't have any clinical trial evidence to know what to do. Advocacy needs to continue to make sure that we have the best drugs where they're needed most. And finally, lumbar punctures to save lives. Thank you very much.
Excellent, David. Thanks. And we will move right in to hear our next speaker, Halima Dawood from South Africa. Halima, please let me know if you would like me to control the slides or if you want to share your screen and do it yourself. It looks like you're currently on mute.
Hello, can you hear me now?
Yes, you're soft, but I can hear you. So speak up, please.
Okay, good afternoon, everybody, and good evening, wherever you are in the world. Thank you for inviting me to share my experience with 5-flu cytosine. So today I want to present a case of cryptococcal meningitis that typically occurs in the South African setting. So it's a 36-year-old man who presented with a 2-week history of progressive headache at the HIV testing site at his local clinic. And because we practice test and treat, he had his routine assessment, didn't have any signs of meningitis, and was started on tenofovir, emtricitabine, and efavirenz. And we generally call these patients back within a week to review the baseline blood results done at screening for test and treat. So a week later, he returned to his clinic and described worsening of his headache. At that point, his CD4 count was noted to be 34, and his basically was referred to his clinic. The hospital called me because his serum cryptococcal antigen was positive, and they already decided to stop his ART. So when he arrived at the hospital, he looked quite ill. He was dehydrated. His temperature was 38.3. His blood pressure was normotensive, and his pulse rate was 78. His temperature was subsequently 36.9, intermittently had temperature spikes during his admission. On examination at this point, he had neck stiffness, but no other focal neurological signs. His baseline bloods, you can view them here, but essentially his hemoglobin was low for a male, and his liver function test was slightly higher than the upper end of normal for a South African male, and his ALP was also elevated. And as I said already, serum cryptococcal antigen was positive. His UNE is on day 0 was fairly normal. His creatinine was 82, the potassium of 4. And so we admitted him and commenced amphotericin B and 5-flucytosine. We had access to 5-flucytosine, thank you to the donation facilitated by MSF. This was his lumbar puncture at admission. So as you can see, all he had was lymphocytes of 32. His opening pressures were 18, but his serum cryptococcal and his CSF cryptococcal antigen was positive. Subsequently, the culture was negative. His ADA was normal, and his gene expert on the CSF, which is not shown here, was also negative. So we continued his amphotericin B we use intravenous Maintenite, which is very similar. It's a dextrose-based maintenance fluid. On day 1, when we gave him the amphotericin B, he developed rigors. We tried some paracetamol. The rigors continued. We tried an antihistamine that didn't help. So we slowed the infusion down. He still had rigors, but he managed to complete his first 3 days of amphotericin, his first 2 days of amphotericin B infusion. On day 3, he was unhappy to continue. And so we tried 50 milligrams of intravenous hydrocortisone, which seemed to work quite well. And we managed to complete the 7 days of amphotericin B together with the 5-flucytosine. In addition to this, I don't know whether it was because we gave him the hydrocortisone, he developed a pyrexia again on day 4 and clinically was in respiratory distress. We diagnosed a nosocomial pneumonia and treated him with piperacillin tazobactam and amikacin. And by day 4, starting on that treatment, he recovered. We did not culture any organism, but his procalcitonin was elevated and subsequently normalized after the treatment. So we managed to complete 7 days of amphotericin B together with 5-flucytosine. As you note, his potassium started to decrease from day 3, despite us already starting supplemental oral potassium. And on day 7, it was 3.5, which we managed to continue with oral potassium, but his magnesium also decreased on day 7. And we only have, the only available magnesium supplement we have in the public sector in South Africa is intravenous magnesium sulfate. So we use that to correct his magnesium. So I think it's time for a poll question, please. So the question is, do you have access to urea and electrolytes at your site? Yes or no? Okay, it seems at least 3/4 of people have access to urea and electrolytes. So subsequent to developing rigors, as I said already, we maintain him on intravenous fluid and we were able to discharge him after his antibiotics. I think we have another poll question, please.
we have results on that one?
I don't see anything on my screen. Oh, there's it. Okay. So I guess the main challenge is measuring of opening pressure. So that is a challenge in South Africa also. The manometers are fairly expensive. So it is quite a challenge to get manometers. So in the final assessment, we had a patient with cryptococcal meningitis who we managed to treat with amphotericin B and 5-flucytosine with minimal adverse events. He was subsequently discharged on fluconazole and was for reinitiation of ART in 6 weeks' time. So I'd just like to thank MSF for allowing us access to 5-flucytosine and the different accesses that helped us to get the drug at our hospital pharmacy. Thank you.
Thank you, Halima. Thank you very much for that interesting case and real life scenario. We've reached the end almost of the hour, and we apologize for maybe trying to run over a few minutes now to try to address a couple of your questions. We're getting lots of fantastic questions. I wish we could stay on and have some rigorous discussion with you all, but I think what we're going to try to do is at least take on a couple of questions. And I have with me here Amir Shrufi, who's also been looking at the questions, hopefully, and has maybe picked out some that might be helpful to address now. So we'll run over here 10 or 15 minutes and again, try to address a few questions. I hope you found this useful. This will be recorded as Bruce mentioned, and we think that we've tried to provide quite a bit of information on slides so that you could have them to review in the future. Clearly, getting 5FC, which really would be the main message of this hour, out to your clinics, your countries, as you can see, will be an incredible, useful way to save lives of those living with cryptococcal disease and HIV. So Amir, perhaps I turn it to you because you may have a question or two that you could throw out there and we could try to address. Thanks.
Yeah, thanks very much, Tom. And we've got some very interesting questions. For the questions that have come through in relation to WHO guidance and in relation to COVID-19 disease, we will try and address those in the materials we send in follow-up. And indeed, we will try to address questions that the panelists cannot answer now in follow-up. So if I could start with a couple of questions for all the panelists on cost and access. We have one question: if liposomal amphotericin B is safer, why is the deoxycholate still the preferred option? And in countries without insurance schemes for a number of patients in need, what policy and programmatic initiatives are in place or will be put in place to increase access to 5FC or liposomal amphotericin B? So would the panel like to answer those points?
Yeah, I mean, these are tough. I'll take a stab, being not a clinician in Africa right now, unlike Halima and you, Amir, and David, who are there dealing with these challenging issues. I think that in settings where it is really challenging to get liposomal amphotericin B, we know deoxycholate amphotericin works well if managed the way David Maya has pointed out today. We know deoxycholate management can be a real challenge in resource limited settings. And I think the good news is that the recent trial data showed that you can reduce the time you use amphotericin down to 1 week. But that all relies on the availability of 5-flucytosine, which we have discussed today, which the questioner also asks access to that drug. And I think Amir, Halima, others, you can comment, but we are working very hard to try to get 5FC into the countries that need it. And if you didn't have liposomal, but you have deoxycholate, you're able to treat for 1 week now with very very successful results that have been shown from the recent trial data. And just a word on liposomal. I think all of us would like to see liposomal more widely available, but at a price that is affordable. And so I think we are all working toward that goal as well. So Amir, Halima, David, any other thoughts or comments?
Yeah, no, so just to jump in here, thanks, Tom. For those of you who are old enough to know about the story of antiretroviral therapy, it's quite clear that, up until 2004, the same argument in Africa was sort of existing about ARVs are too expensive to have in Africa, and we just can't do anything about this. But I think what eventually happened is that people just didn't throw their hands up in the air and say, this is impossible, let's just live with it. I think there was a lot of advocacy that sort of went into discussing with pharmaceutical industries, and so it's the same. I think it's the same thing that's happening right now with liposomal amphotericin. 2-3 years ago, we would not be having this discussion at all on flucytosine or the possible availability of Ambizon in sub-Saharan Africa. And so I think we just need to remain very optimistic that these drugs will be available at prices that will be hopefully afforded by the governments as well.
Okay, thanks very much, David. Maybe another question that's come in that I think you did try to address during your presentation, but it's a very important question nonetheless. In a country where amphotericin B is not available, what is the alternative? So what do you say to people working in settings where they can't get amphotericin B?
Yeah, David, do you want to try to take that one first?
Sorry, I think I lost a bit of a connection.
Sorry, yeah.
Did you hear the question, David?
Tom,
Yeah,
you may want to ask Halima if she wants to catch this one.
Yes. Yeah, Halima, what are your thoughts on treatment for cryptococcal disease without amphotericin B being available?
Okay, so I think David nicely showed the second option that was studied in the ACTIVE trial, which is 5-flucytosine together with fluconazole as an alternative. And the advantage of that is an oral regimen. And I think it came up as the second best regimen as an alternative. So in South Africa, we've also recommended that as an alternative when amphotericin B, when there's an amphotericin B stock up.
Okay, no, thanks, Halima. So it's it's a very sort of important fallback option indeed.
When trial data came out showing that 5-FC plus fluconazole performed very, very well, just slightly below what deoxycholate and 5-FC did. And, that was really heartening for me because that is, as you're saying, Halima, an all oral regimen. The challenge, obviously, again, is the availability of 5-FC. And so it's really the drug that we in the cryptococcal community that are advocating for drug availability are working the hardest on right now, because combining fluconazole with 5-FC looks very efficacious for treating cryptococcal meningitis, and certainly in settings where it's hard to hospitalize patients or give IV therapy. This is a really exciting option. Now, the problem being, as many of you are, in fact, most of you, I would imagine, do not have access yet to 5-FC. And if you do not have 5-FC, which most of you don't yet, and hopefully that will change soon, and you don't have deoxycholate, you're left with fluconazole. And you're left really pushing the dose of fluconazole up as high as you can. I think that no matter what, the unfortunate news about fluconazole is fluconazole monotherapy for people very sick with cryptococcal meningitis does not work very well. But if that's all you have, I would recommend starting with high dose fluconazole and then trying to see if it's possible to get the patient to a place where amphotericin B is available.
Okay.
David, are you back on? Did you have any comments? The question was, if you don't have amphotericin B, what do you do? I don't know if you had anything to add to what I said.
Yeah. No, I think you summarized it pretty well. You summarized it pretty well.
Okay, no, thanks. Thanks, David, Tom, Halima. A couple of questions about how the COVID response may be impacting the ability to manage patients. So the first question is, for patients on chronic medicine, so whether, and that could be antiretroviral treatment, or it could be for the consolidation and maintenance phase of crypto treatment or TB treatment, how will patients be able to get their medicine when access to services is being restricted and services are being closed down? So that's the first question. And then another question more specific to crypto, given that access to CD4 triggering a CRAG screen is poor and that CRAG screening may not be being rolled out at the moment, in light of COVID, could there be merit that patients clinically stage 3 or 4 all receive a course of fluconazole similar to what was given in the reality study? So I guess the question there is, you know, we're recommending that all the CRAG positives, even without symptoms, get a lumbar puncture, and the question seems to be, does that warrant some reconsideration? So I don't know, David, you seem to have some thoughts on the issue of chronic medicine supply. Do you want to have a go at that?
Yeah, so this one of the things that we've done in Uganda, we've you know, right at the time that the lockdown was starting to be implemented, one of the things that we did is we partnered with you know, there's motorbike transport companies and ensured that supplies were provided to patients, you know, to last them for about 2 months. Of course, this all entirely depends on the availability of the drugs in the first place. And so for those places, I think where the fluconazole, for example, is available, I think just ensuring that you either reprogram funds or work with the Ministry of Health or implementing partners to just make sure that drugs do actually get delivered to participants. Again, in the context of ensuring that both the participants and the people who are delivering the drugs obviously maintain, you know, the whatever measures are being implemented by the Ministry of Health in terms of the COVID response, I think is something that needs to be considered. It's difficult for patients to obviously have transportation to go to the facilities where they usually get treatment from. But I think, you know, it's considering the reverse, I think would be important, that the healthcare providers, you know, implement some other measures to make sure that patients do get their drugs.
Yeah. Does anyone else want to respond to either of those questions?
I would make a quick comment. I mean, these are certainly the challenging issues. This is one of the reasons we're here today, is to just let people at least be frustrated about some of the realities of taking care of patients right now during this pandemic. And I certainly think we're all frustrated. I do think it does call for you know, strategic ways to cope with the fact that patients can't visit you in your clinic. Patients can't potentially get access to CD4 and can't be evaluated appropriately. And certainly we know stage 3 and stage 4, if you're able to stage patients in those stages, are at risk, certainly if they're not on antiretroviral therapy, are at risk for opportunistic infections. And even if they are on ARVs and for some reason can't get them. So I do think that in situations, depending on how you evaluate them, that there could be a role for prophylactic fluconazole therapy as a stopgap measure while you're waiting to be able to get the patient into clinic. Now, that provides you can get fluconazole and you can get them on it, but as Amir suggested and as the questioner suggested, there was a trial that did show some benefit from taking prophylactic fluconazole. And I will say that with a lot of caveats because those patients were also on other medicines. So there's still a question. We don't advocate widespread fluconazole prophylaxis use. We advocate a screen and treat approach, but we're in a very challenging moment where there could be gaps. And so I do think all things should be on the table for consideration, especially for those patients that are very sick and that we want to save their lives. So it's a good thought. We don't yet have necessarily a strategy for that, but I'm glad people are thinking about it, discussing it. I still think the best thing to do is to get people screened and then act appropriately on that cryptococcal result.
Okay, no, thanks a lot, Tom. And then we are running over time. We appreciate people's attention. I think perhaps maybe one final question. Again, I think it speaks to the challenging settings that many of you work in. The questioner asks, in a situation where there is no equipment to analyze the CSF, what is the bedside diagnosis that can be done to diagnose cryptococcal meningitis? So I think again, you touched on it, David, in your presentation, but maybe just an important point to stress.
Yeah. So I think one of the most important, diagnostics, especially as far as advanced HIV disease is concerned, has obviously been the lateral flow assay. And I know that there's a couple of companies out there now that are making this lateral rapid diagnostic test. I think having access to that is clearly important because that tells you about, whether somebody has cryptococcal disease that is asymptomatic by doing the blood test, if their CD4 count is less than 200, and then offering preemptive therapy, as Tom said, or it tells you that somebody who has symptoms of meningitis and you have been able to do a lumbar puncture right at the bedside, that you're able to put 2-3 drops of CSF on that, the LFA, and you're able to determine that this person has cryptococcal meningitis because they have a positive CSF CRAG. And so right away, you don't need lab facilities, you don't need to have power, you don't need to have expert training. Once you're able to just do that LFA, it will be sufficient to tell you that you need to start this person on treatment for cryptococcal meningitis.
Great. Yeah, no, thanks, David. Sorry, Tom?
No, I would just say second to what David says, and that, I think that if you're unable to get CSF, I think the advantage of the crypto test is that it is highly sensitive in blood, sera, plasma, and so it's a great indicator, certainly in a symptomatic patient, that there is something going on in the CSF. Clearly, if you can do a lumbar puncture for therapeutic reasons, that's one of the essential ways to take care of very sick people. But if you're unable to, and you had a blood test that was positive, I think you would assume that they had cryptococcal meningitis. I think we all probably feel that way as clinicians. So I would say, Amir, just given the time and given the fact that we're over and that we're thrilled that people stuck around, we want to end this wonderful webinar session. Thank the folks at ECHO for helping us put this on. We had a great presence, it looks like, just looking at the views, and the questions have been fantastic. I think we will try to use these questions to come up with a frequently asked question page. And so we will get together and try to put some of these online so that you see some of the answers and our thoughts on these questions. And I think we will try to continue this webinar format for advanced HIV moving forward, especially in this time, in this unprecedented time of the COVID pandemic, where we really need to continue to communicate with each other virtually. So I want to thank, Halima, thank you so much. Thank Amir. I want to thank Bruce, the staff, Jutta, Constance, David Maya from Uganda, Alex Jordan from our group here at CDC, and just give everyone a warm thanks for joining us. And we look forward to virtually seeing you hopefully soon in the future. Thanks a lot.